Good morning, everyone. I would like to welcome you all to today's meeting on issues of mental health in Malaysia. My name is Siti Maimunah, and I will be serving as the chairperson for this session. Joining me today are Miss Mimi, a social welfare and community outreach officer, Miss Irdina, mental health policy and psychological research analyst, and Miss Thanussha, a public health specialist. Our main objective today is to assess the current proposals and work toward collecting the best strategy to improve mental health initiatives across the country. To keep things flowing well, please keep your opening remarks within 1 minute. Let's begin with your initial thoughts, Miss Mimi. What is the current data telling us?
Thank you, Ms. Maimunah. To begin with, current data shows that mental health is an increasingly serious national concern. Well, according to the National Health and Mobility Survey in 2023, around one-third of Malaysians are experiencing mental health challenges, particularly anxiety and depression. What is even more concerning is that many of these cases remain unreported due to stigma, fear of judgment, and possible social or professional repercussions. At the same time, we are witnessing a noticeable rise in distress calls and help seeking behavior, especially among teenagers and working adults. While these challenges are often linked to financial hardship, academic and workplace pressure, bullying, and ongoing family conflict. So, altogether, this suggests that mental health issues are deeply connected to both social and economic stresses in everyday life. With that in mind, Ms. Thanussha, from a public health perspective, how do you see our current healthcare system coping with this growing demand for mental health support?
All right, Miss Mimi. Building on your points, we must address the treatment gap in our current infrastructure. While awareness is increasing, our specialist to population ratio is still a major hurdle. Currently, Malaysia has roughly 1.3 psychiatrists per 100,000 people, which is far below the World Health Organization's recommended ratio, which is 1 to 10,000. This shortage leads to months-long waiting lists in public hospitals.
I also agree with Ms. Tanusha's point on the treatment gap. And in another perspective, which is psychological perspective, however, this issue also lies in what happens to how individuals like while they are waiting for the care that they need. So when mental health issues are left unmanaged, like these individuals may develop into negative psychological effects, particularly on their emotions and also thinking patterns, which can lead to change of behavior of the individual itself. So, for instance, okay, there's research during COVID-19 pandemic in Selangor that found around 53.9% of students experience moderate to extremely severe depression, while 66.2% reported moderate to extremely severe anxiety. So, these emotional struggles may negatively impact academic performance, workplace productivity, and interpersonal relationships. So, over time, this will unfortunately contribute to like a burnout, family conflict, and in severe cases, a suicidal behavior.
Thank you for all the problem statements. Before we dive in, I would like to remind everyone that our goal today is to identify not just uh, which proposal stands out, but how these three can complement one another to form a cohesive national mental health strategy. Now, let us take a closer and more detailed look at the three primary proposals that have been developed for this initiative. These proposals include first, nationwide social awareness and anti-stigma campaigns presented by Ms. Mimi, implementation of the WHO Mental Health Gap Action Program, MHGAP, by Ms. Thanussha, and early psychological interventions and mental health literacy programs by Ms. Irdina. So let us begin with the first proposal. Ms. Mimi, as someone with extensive experience in community outreach, could you elaborate in how your campaign approach might look in practice?
Sure. So, from my perspective as a social welfare and community outreach officer, I strongly support the proposal for nationwide social awareness and anti-stigma campaigns. To begin with, stigma remains one of the biggest barriers preventing people from seeking help. While many individuals still fear being judged, labeled as weak, or misunderstood by their families and communities. Also, research by Hamza and Utsman in 2024 shows that negative social perceptions often discourage open conversations about mental health, even among close friends and relatives. As a result, problems that could be managed early may escalate into more serious conditions. Therefore, these campaigns should not only focus on sharing information, but also on changing mindsets. By using real life stories like social media, community leaders, and school based programs, we can normalize discussions about mental well being and show that seeking help is a sign of strength, not weakness. At the same time, we must ensure that these efforts reach both urban and rural communities so that no groups feels left out. However, awareness alone is not enough. If more people are encouraged to come forward, we must be confident that our healthcare system is ready to support them.
That is a strong
While
and well-rounded perspective, Miss Mimi. You have highlighted not only the emotional and social dimensions of stigma, but also link it to a system readiness, which is a very practical point. Thank you for setting the stage. Now, Ms. Thanussha, could you build on then by explaining how the MH gap framework could realistically strengthen our social healthcare capacity?
All right, Miss Maimunah. So while Miss Mimi focuses on awareness, my proposal addresses the service gap by implementing the WHO Mental Health Gap Action Program, which is MH-GAP. We utilize task shifting to train medical officers in health clinics to manage mild to moderate cases. This decentralizes care, ensuring patients to get help at the community level instead of waiting months for a hospital specialist. From a public health perspective, this is a vital economic investment. Mental health issues currently cost Malaysia 14.46 billion ringgit annually in lost productivity due to presenteeism. By integrating mental health into primary care, we create a proactive safety net that prevents patients from reaching a crisis point that requires expensive hospitalization. So, this model reduces the burden on our tertiary hospitals and ensures a more sustainable, accessible healthcare system for all Malaysians.
That is an excellent explanation, Miss Anusha. I really appreciate how you connected the economic service and preventive aspects. The idea of task shifting is quite timely, especially when we consider the manpower limitations in our current mental health services. Now, Miss Irdina, you have been listening closely. So, could you share how your proposals for early psychological interventions and mental health literacy fits into this ecosystem?
Okay, thank you, Miss Maimunah. Okay, well, I support Mimi's proposal on the anti-stigma efforts and Thanussha's focus on addressing the service gap. And I would like to add more, which I want to focus on how we strengthen the early psychological interventions and mental health literacy, which is particularly in schools, university, and also workplace. As an example, it should include like interactive sessions between trained mental health professionals and students. So while we implement school-based mental health education that focus on emotional regulations and also coping skill. So with the help of more structured mental health screening, like counseling services and also psychological skills training, such as stress management, emotional regulation, and also problem solving, we can actually intervene the problem before the conditions become even more serious. So that from me.
Okay, thank you everyone for the thoughtful ideas you have shared. Each proposal tackles an important piece of the mental health and issue, from raising awareness to improving systems and focusing on prevention. Before we move on, it's really encouraging to see how these ideas support and build on one another rather than compete. That suggests a combined multi-approach could be the most effective for Malaysia's mental health strategy moving forward. So now let us focus on feasibility, looking at which ideas are realistic and sustainable with our current resources, policies, and social needs. Let's begin with the first proposal. So, Ms. Mimi, from your perspective as a social welfare and community outreach officer, how achievable is a nationwide awareness and anti-stigma campaign, both in the short term and in the long term?
Well, from a social and community perspective, A nationwide awareness campaign is highly achievable, especially in the short term. We can build on platforms that already exist like schools, universities, social media, and local community programs, which means we don't need to create entirely new systems. So this makes it practical and cost effective. In the short term, we could organize school talks, workshops, online campaigns, and community dialogues. These initiatives encourage people to share their experiences and increase visibility at the grassroots level. Whereas for the long term, the key is integration. If we embed mental health awareness into school curriculum, workplace training, and community programs, it becomes a natural part of daily life. Sustainability will also require collaboration with NGOs, government agencies, and the private sector to provide funding, monitor progress, and ensure that the campaigns are effective. Overall, I believe such campaigns are realistic, scalable, and can gradually reduce stigma across Malaysia. So, with these strategies in place, we can start small, build momentum, and eventually integrate awareness into everyday life, which make the plan more workable and sustainable.
That is a detailed and balanced view, Miss Mimi. I appreciate your emphasis on scaling gradually and building on what we already have. So the phase implementation strategy actually makes particular sense in ensuring steady growth without overextending our resources. Now, since you mentioned long-term sustainability and system readiness, let us turn to the healthcare perspective. Ms. Thanussha, how does your MH gap proposal fare in terms of cost, practicality, and implementation within our existing healthcare setup? Thank you.
Alright, Miss Maimunah, the practical feasibility of the MH gap lies in its strategic utilization of Malaysia's established healthcare architecture, especially the network of over 1,100 health clinics, which allows for immediate nationwide implementation without the prohibitive delays of building new facilities. So, by championing a task shifting approach, the program upskills existing medical officers and primary care providers, transforming them a frontline defense against mental health disorders and effectively bypassing the years long specialist bottleneck. So, this transition from a reactive tertiary heavy system to a decentralized preventive model is fiscally transformative. So, treating patients within their own communities is significantly more economical than the high cost management of the late stage crisis or chronic hospitalizations in specialized psychiatric centers. Furthermore, by addressing mental health concerns early, we directly tackle the 14.46 billion ringgit annual productivity loss caused by absenteeism and workforce exit, safeguarding the nation's human capital. Ultimately, this approach ensures that mental health support is not a luxury for the few, but a sustainable, accessible, and dignified right for the B40 and M40 groups, fully integrated into the existing national health budgets. Thank you.
Well, that is a very practical insight. Thank you, Ms. Thanussha. I appreciate how you frame it not only as a healthcare improvement, but as an economic and structural reform that strengthens the system's efficiency. It's reassuring to see that your proposal aligns with existing health infrastructure rather than relying on entirely new frameworks. Now let's turn to our third perspective, Ms. Irdina. Teaching young people about mental health and building emotional resilience sounds like a powerful preventive tool, but in practical terms, what will implementation look like across schools and workplaces?
Okay, thank you, Miss Maimunah, for the question. Well, realistically speaking, teaching mental health in schools and workplace is actually does not require like creating entirely new systems actually, but rather we have to strengthen the structure that already exists. Like in schools and universities, mental health education can be delivered through short, structured campaigns that integrated into existing health education or their co-curriculum programs like focus on emotional regulation, stress management, and also coping skills. So another point, which is how to improve feasibility. So schools can collaborate with mental health organizations, private clinics, and maybe NGOs or corporate partners that are willing to provide screening, talks, or counseling services at low or even no cost at all. So in return, these organizations can gain visibility, community trust, and also corporate social responsibility recognition. So it's actually a win-win situation. So this type of school-based mental health campaign actually allows services to reach students without placing like a heavy financial burden on the education system, which is a very similar approach we can apply also, implement it into like workplace through brief workshops or existing employee assistance programs, which is EAP. So in overall, this approach is sustainable because it combines early psychological intervention with public and also private collaboration. So which is we can reduce the long-term pressure on specialized mental health service while we also promote the well-being and also productivity.
Alright, that is an excellent point, Ms. Irdina. So the integration of public-private partnerships and utilization of existing platform make your proposal both cost-efficient and forward-thinking. It also creates continuity between early education and adult mental health literacy, a full life cycle approach. It's clear that collaboration and integration are recurring themes across all three proposals. They make each approach more achievable and sustainable. Miss Mimi's awareness campaigns lay the groundwork by shaping perceptions. Miss Thanussha's MH Gap strengthen our service infrastructure. And Miss Irdina's education initiatives invest in long-term resilience. We have now assessed the feasibility of each proposal from social, healthcare, and educational perspectives. Let's proceed to finalize our decision and formulate an action plan that combines this idea into a unified and implementable framework. Each person will handle one key area. Start from you, Miss Mimi.
Okay, so as for the action plan on awareness and anti-stigma, we will start with a phased approach. In the short term, we can hold speeches, seminars, and campaigns in schools, on social media, and through community initiatives. Also, by engaging with students, NGOs, community leaders, and even business partners, we can ensure that these projects reach people of all ages and backgrounds. Whereas the long-term goal is to institutionalize mental health awareness. This entails incorporating mental health education into school curriculum, job training, and community initiatives, making it a part of everyday life. Well, regular evaluations will also be necessary, like monitoring engagement, obtaining feedback, and interacting with stakeholders will allow us to determine which techniques are most effective and make changes as needed. So what do you think, Thanussha?
So that's a great plan, Miss Mimi. The integration of MH Gap into the primary healthcare ecosystem will be initiated through strategic pilot projects at selected health clinics, focusing on upskilling existing medical officers to bridge the treatment gap at the community level. So, by equipping these frontline clinicians with standardized protocols for the assessment and management of mental, neurological, and substance use disorders, the program transforms the health clinics into a first point of contact for mental health. So, in the long term, this initiative will scale nationwide, supported by a framework of continuous training and clinical supervision to ensure the sustainability of care standards. So, this decentralized model significantly enhances accessibility by bringing services directly to the people, effectively removing the geographical and financial barriers that often hinder the B40 and M40 communities. So, ultimately, by shifting the focus toward early intervention and local management, the program will reduce the national healthcare burden and long-term economic causes associated with late stage psychiatric complications and lost workplace productivity.
Okay, so I will continue on the perspective of education in schools and also workplace. So, long short story, we will have to strengthen the existing systems. So, in the short term, we will run like workshops and talks with NGOs and also professionals. While the long term, we will work on the mental health literacy that will be part of school curriculum, which is will be upgraded both in school curriculum and also the EAP Employee Assistance Program. So that's all for me.
All right, thank you everyone. So, in summary, Miss Mimi leads awareness, Miss Thanussha handles MH Gap, and Miss Irdina manage education programs. We will monitor progress together every 6 months to ensure mental health care becomes more visible, accessible, and sustainable in Malaysia. All right, I believe we have reached a clear direction with our plans. Before we close, let us hear a quick word from each of you. I just to wrap up our discussion today. Miss Mimi, can you start, please?
Okay, thank you. Overall, I completely agree with the plan that we've outlined today. From my perspective, real change begins with the community. When people feel safe to talk, supported by those around them, and confident that help is available, they are far more likely to take the first step toward recovery. With strong teamwork between policymakers, healthcare providers, educators, and community leaders, I truly believe we can reduce stigma, strengthen social support systems, and build a more compassionate and understanding environment for mental health across Malaysia. So once again, I'm very encouraged by the collaborative approach we're taking, and I look forward to work closely with all of you to turn these ideas into meaningful action.
Well, I agree as well with Miss Mimi's point. So our health system is ready for this shift. With strong collaboration, we can make mental health care more accessible to every Malaysian. So what about you, Miss Irdina?
Okay, yes, I agree as well. Like our health system is, sorry, education and awareness. Actually, we must start it very early, and with the right partnerships, we can make a lasting change in both schools and also workplace.
All right, thank you everyone. It's great to see we are all on the same page. Together, our combined efforts, awareness, healthcare, and education can create a sustainable and inclusive approach to mental health. Let us continue working hand in hand to make this vision a reality. If there are no further comments from all of you, I hereby declare this meeting adjourned. Thank you all for your valuable contribution and insights today.
Thank you.
So
Thank you.